Hi, my name is Diane, and I'm a board certified psychiatric nurse, and I'm here to talk about recording, recognizing, documenting, observing changes in patients and condition. This is part 5 of a 6-part series in mental health care for nursing assistants, direct care staff, and other paraprofessionals. So I'm going to share my screen so we can look at the PowerPoint. So how to recognize changes in resident status or condition, which is a super, super important part of anybody's job who works with patients, and particularly the frontline workers who I'd like to think of as the eyes and ears and voice of patients. I mean, you have the larger doctor, nurse team that designs the treatment plan and oversees the actual care, kind of develops the roadmap, and they are the architects of the plan or the blueprint for this patient's care. But the direct support staff, the paraprofessionals, the nurses and nursing assistants, they're the ones that actually implement the care. So super important for the person to know what the plan of care is, what the diagnoses are, and what the outcomes are expected. So when you don't know what the plan is, you certainly can't recognize if it's effective or it isn't. So ideally, optimally in a work environment, people would have the same patients in a team over time. So when you have the same patients or you have consistency, you get to know them on a personal level and a professional level, and that combination can help you provide much better care. So the objective for this section, which is about 1/2 hour long, is identifying why recognizing change is important, the importance of understanding patient baseline conditions so changes can be noted, why detecting changes are important, and monitoring for change and following up if change in condition is noted. So basically, for you to notice a change in anything, you have to know where you start or what your baseline is. Just like when you go on a diet, you kind of need to know you weigh 162 pounds and that you want to go in the direction of 142, for example. So your baseline is where you start, what your go-to every day is. So if somebody is unsteady and unwobbly on their feet as a baseline, uses a walker, needs a system 2 to the bathroom or whatever, then it would be unreasonable, or maybe it would be a really happy circumstance if all of a sudden they jumped out of bed and did not require assistance. So the baseline, if this person is assisted to, or could maybe transfer with the assistive 1, if somebody then required massive a Hoyer lift to transfer, or assistive 2, or could no longer ambulate with assistive 1 for 20 feet and could only go 10 feet, that would be a change in condition. Now, normally changes in condition are unfortunately negative things. You could report a change in condition if you were monitoring for someone who perhaps had depressive symptoms and they were ordered an antidepressant, and all of a sudden you noticed that they were more interested, invested, wanting to go to the activity room or whatever. That would be a positive change. But for most of the intents and purposes of this training, it would be the averse types of changes that warrant reporting to either the supervising nurse or any type of leadership, for the most part. So the role of nursing assistants in detecting change in residents, of course, I've expanded this to, I mean, anyone that interacts with the individual is responsible for knowing the patient, knowing their baseline, and knowing a change in condition. Not only understanding that there is a change, but reporting it through the right channels to the right people so the right care can be implemented. So like I said, if you work with the same group of people on hall number 3 or in annex number 4, and you kind of all know of your people, then that's the most optimal thing. If you take care of Mrs. McGillicuddy in room 303 every day, then you're more likely to know her ins and outs, her nuances, and recognize things much more quickly than somebody who maybe were just on shift for the very first time. And when you work synergistically within the same group of people, kind of sharing patients, then you have someone else's observations to bounce ideas off of and think about. And so in the best case scenario, you have a team of people that work together that know. Now, there's always going to be some time where there's a new patient that you don't know. There's always going to be the time when everyone gets sick at the same time and everybody calls off and you are thrown into a place and you don't know the people at all, which means you need to up your A game and know what the patterns or what the policy for yourself and your personal practice of care for your job would be, how to get the baseline information that you need to provide the best care for that patient. So when I think about who interacts the most with these people in a either assisted living, long-term care, or independent, whatever type of situation, are those frontline workers. Most of the people that are involved or come to live in these places need care of some kind. So they need some kind of direct either IADL or ADL support. So that's the people that are right up there implementing those interventions. So you're the first line, you're the frontline worker. And so are physical, in some regards, speech therapy, occupational therapists, even if there's a activities assistant, anyone like that, maybe even secretarial that walks through every day and they know the certain cadence and rhythm of the unit and they realize, well, something's wrong. We all have a personal responsibility in providing optimal care for our patients, residents, consumers. So dietary as well. So I did talk briefly about a consistent workload, what you would like optimally, of course. Particularly in COVID times, you don't have a lot of control about those things. So you may just be like flying from, you might be off your schedule. So there are some ways that you can make yourself more safe in patient care and then optimize your delivery of those services. And so, so when you work as a team, when you work with the same people, the chances that changes, remember, the negative changes are seen a little earlier, interventions can occur earlier, treatment can occur earlier, and then of course the patient has a better chance for a good outcome. And so, but even so, changes occur over time, but with the elderly, disabled, kind of like more acutely ill patients or medically compromised patients, changes can occur like that. It can occur in a minute, it can occur from shift to shift, and it can occur during your shift. So frequent check-ins, no matter whether you're the first time you've ever been with a patient or it's somebody that she's been there for 3 years, you know her routine, still having your own personal discipline of checking in frequently, and then checking in with yourself and checking in with your patient, is still everything okay? Particularly during flu season, times of like distress, medication changes for that patient, life changes, a lot of things happen for people when they're older or whatever. So frequent check-ins throughout the shift are important. So you have a responsibility to know your resident, patient, consumer baseline. It's your responsibility. You cannot possibly give good care if you don't know and understand what care is needed to give this patient the best care. If the patient has a history of constipation, then you should know without looking when the patient's last bowel movement was. And you could go look it up, but really, if that's the care that you're providing, that should be something that's just in your mental mindset when you go to look for this patient. If you know that they're a diabetic, then you need to know, okay, this patient is on insulin, so I need to be really kind of astute for signs and symptoms of low blood sugar, or I have to be really careful about her. She stays late in the activity room, and sometimes she misses the first, round of dinner. So those are some things that you could really do, but to optimize their care. So if you the first thing that you need to do, and if you work with consistent patients, then you can do it it's part of your like toiletries of the day. I don't know, your personal hygiene practice for your shift is that you run in and you say, hey, what's new, what's changed, what's different, um, what's happening with my patients. If you've gone away, if you've worked 5 days in a row, you probably have a good, run up to the last 5 days and you understand what's happening. If you're off for 3 days, all bets are off. Some things could be very different. You need to know, have they had any symptoms, any new change in diagnosis, any new change in meds? Have they had a good bowel movement? Anything like that. And the time to know is at the beginning of your shift so that you can incorporate that into your plan of care. And I stress constipation because that seems to be the number one thing that I deal with all day long with my residential providers, our partners. Constipation, like they should know when was the last bowel movement, because so many people get sent out to the emergency room or for x-rays or whatever because they're like, well, I don't know, we really don't even know, like maybe Thursday. So, and that is really part of, and you probably have learned this before, like the fatal five, that can really cause some real, it's just not being backed up, it can cause some real life-changing and altering conditions for patients. And also urinary patterns, possibilities of UTI, blood sugars, all of those things that you should know. And you can do that very quickly by going to work maybe 3 or 4 minutes earlier, just scanning through any changes, and then being prepared for your shift. If you're new to the patient, then it's even more essential to go get that information and make sure that you have what you need so you can provide great care. The other thing is, and other than knowing, the basic diagnosis change, diagnoses in general, whether or not they've had a good bowel movement, have they had any illness symptoms, any change in vital signs. The shift-to-shift report is important. Ask your coworker who, what, where, when, how, and why, or however you structure your questions in a very easy to relate format. I work with residential treatment facilities, and every week I will call for a report and say, well, I didn't work yesterday. I didn't work over the weekend. They don't know. And so a lot of times, like a lot of my efforts are to get them up to speed with patient handoff or shift-to-shift reports. You can look at the narrative charting. You can look at the flow sheet charting. But in addition to getting your information from there, which sometimes is digging, you also need that narrative subjective impression of the person that's leaving the shift, saying, something's not right with Mrs. McGillicuddy. She seems okay, but like, I just got this sense. You pass that on. And then you should always keep your assessment skills up to date. I know that we are right in the middle of COVID, but now we're just like, it's rote and routine that we know their temperature right off the bat. But that was maybe a year or so ago, that wasn't on our radar. So just know that every day in healthcare, we could be looking at something different, and to basically understand that a basic assessment, vital signs, did they go to the bathroom? Are they in any pain? Are there any change in condition? Any new medications? That should just be part of your personal practice. Even if you're not a nurse, you're still responsible as part of an expanded team for knowing what's going on with your patient and changes in condition. I want to make sure that I am not going to go over. Okay, good. So the importance of knowing the baseline condition, I probably went over all of this already. Who is responsible? Where do you get your information for the baseline condition? Obviously from the chart, from the treatment record, from the home health aid plan of care, you would get your baseline, the diagnoses, just kind of like the black and white, the play-by-play for the patient's day. But there's also, like, I'm a baseball fan, so there's always the play-by-play that tells you who's on first, who's blah, blah, the ERA. But you also always have the color commentator who tells you, like, kind of like fleshes out all the details about someone so you get an expanded picture. So you can get all of this. He went to the bathroom, blah, 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 from the treatment or from the report. But there are also other places that you can get information, visitors, their impressions of family visitors or family, other people's gut, dietary people who say, this is the 5th day in a row that she did not eat her clementines. She always eats her clementines. That isn't really something that you run off and report to the supervising RN, but it's something that you tuck away. Something going on here, and you might be able to ask if they're cognitively aware or verbal, and a reliable historian. You might be able to ask them, hey, Mrs. Tic Tac, what's going on? You always, and she might say, I'm just sick of them. Or she might say, I don't know, I have a sour stomach. So the patient is an amazing source, and really you should validate some of your observations against them if they're able to reply in a meaningful way. But they're not always going to say. A lot of older people won't, they'll deny pain, or they say, oh, it's all right, I don't want to bother you. So you kind of have to weave in and out of that, but you always invite them to the conversation because it's their life. So things that you want to be looking for, what is something so subtle that could be like your gut? When I think about how much information we see at any given time, like at any given time in your life, your eyes are taking in maybe, I don't know, like a gazillion, a lot more than you recognize. Like while I'm sitting here, outside my window, there are birds, there are cars going past, buds are probably shaping up to bloom. There's a chipmunk, the wind is blowing, but I'm paying attention. I'm focusing on this seminar, so I don't know it. My dog's running about somewhere, there's a dog barking. So I have this amazing ability to filter out what I need to focus on in the day. You do as well. But that doesn't mean that a lot of other information we're not being able to absorb it. So you may be recognizing something that you're not on your radar, so to speak, but your gut is telling you, oh, something's not right. It might not have been the first thing you're thinking about. So if you have a gut about a patient, you may have recognized something that you can't really call up to your consciousness right away, but there might be something like, something's not right. Do you ever get a feeling like something's not right here, but you don't know? It might not have been something that your brain cells were focused on at that time, if that makes any sense. So if you have this gut intuition, gut, whatever, it could have been that you recognized that something was awry. And it might just mean that you would go check on this person a couple more times. So sometimes their energy is different. Somebody's usually upbeat, ready to go, and they're just not so much. Could be that they were up all night watching The Godfather reruns, or it could be that something's going on. Sleep patterns, alertness, ability to move around, ability, and sometimes the ability to do IADLs or ADLs, whether they want to participate in treatment or activities, whether they're stopping going down to the activity room. It could be that their favorite show is on at that time, and just like it's a 5-day recap. So for 5 days, they decided not to go to bingo, that they really wanted to watch the show. Well, okay, that seems reasonable. But if they're isolating because there's a bully in the activity room, or they don't feel good, or they're really sad that their dog died, that's a whole different story. So you want to listen to the verbal reports from the family, visitors, and residents, and you're always a big participant in their care and advocate for them. So let's see what else. So tips for detecting change. So I always think that there are two things, physical and non-physical. And we'll get into those in a little bit. But when possible, work with consistent residents. When not possible, know your business, know what you're supposed to know about that patient. Make it your business to know, because you were hired to do a job, and the job is to advocate, provide accurate, timely care, and observe and report changes in condition to the nurse. And remember, the nurse may see these patients once a week, twice a week, once a day. They're not frontline workers, so the expanded team is relying on your accurate assessment and documentation and reporting of possible changes in condition. I have this little thing that I use, and people laugh at me, but I always write, I put little on my notes, I take a lot of notes, and I write the circle of probability, the circle of possibility. So somebody will say, JK just seemed really, his leg just started moving all day. It's all right, 12:31. Ramon says, JK's leg. So that's a circle of possibility. I'm like, oh, somebody said it. And then maybe a week later, Alice says, JK's leg keeps moving. Yeah. Or they'll be saying something, he just keeps on going like this or making some kind of move. And I'll be like, okay, and I'll write all these random things down that people say that are unusual, but don't seem very notable. And when they start, let's say 2 or 3 people start saying the same thing, I move it over to the circle of possibility, which is a lot smaller. And then I try to hone in on that. We do data collection where I work. And let's say that there's so many things that you collect data on. So you always want to get the one thing, the couple things that are really going to give you bang for your buck, things that will really move your treatment forward, the things that will make the most impact. So when I see repetitive behaviors, I work with a lot of people with repetitive behaviors that seem to come into focus and are more problematic. Then that's when I start to shape up, I think I'm going to report this and this and this. It's been pretty consistent over time, that kind of thing. I flesh it out a little bit more. It's real quick and easy to do, and I find it super helpful. And then I can go back through and they'll say, hey, when did we first notice that? And I looked at the first time we really didn't start a treatment for it until February 15th, but on 12/31, that was the first time I heard it. So anything new or unusual or different, I write in my circle of possibility. So when you're looking at somebody, bowel patterns, like I said, energy, bowel, sleep, appetite, ability to do IADLs or ADLs, those are things that you really want to hone in on. And your intuitive sense, because your patient is, something's not right. Something's not right. And it's only a conversation. So have it. Advocate for your patient. I think that there was a study done that, because people were like, they said, I told the nurse she didn't listen, and, but, nurses have a gazillion things to do too. Like we all have our roles, we all have our jobs, and we don't understand what the other person does. And we always kind of don't think they do as much as they do when they're really doing a lot. So I think it takes the average, there was like some kind of study, 3 to 5 times of reporting to get a whole full functional or whatever assessment done by the nurse for those complaints. Not you're in diabetic shock, not cheap out, but like little nuance, like, I think it's not, I think. So it usually takes about 3 or 5. So it's just a lot, it's just the way it is. Just like in marketing or sales, they say somebody has to click on an email at least 7 times or before they'll see it about 7 times before they click on your email or whatever. So it does take that long. Sometimes if it's a very vague and just kind of an intuitive thing for somebody to say, okay, all right, I'm going to come check that out. Something like frank bleeding, falls or whatever, of course, you're right on it all the time. That's what the bulk of their energy and efforts are done, that it's committed to every day. But so don't give up faith or don't think people are ignoring you. It's just the way human nature is and the way things are, what floats to the top in the order of importance for whoever that person that you're asking, because there's a lot of important things that are going on with elderly people with disability or people in placement. So they have to kind of triage them. So learn how to speak succinctly, clearly, give them pretty much objective and subjective information, and you'll have a better chance of getting your needs met by being heard, and the patient will get their needs met by being seen. So observation and reporting suspected changes You have a responsibility to observe, of course. You can observe changes by knowing, you know what's changed because you know the way they usually are. People are dynamic organisms, so you're never the same person every day, but pretty much your patterns are. You know, like if I don't get up in time to drink coffee in the morning, I'm kind of cranky, and I'm usually not cranky. So but you know, if I just hit the ground running, I'm like, by 10, I'm like, ugh, world stop, I want to get off. So like your patterns um, are pretty predictable. So when I get really cranky midday, if I do, then everybody knows she didn't have her coffee. But like if I said, no, I drank coffee all day, that might have been something that might be a little more unusual. So you need to know who they are on a regular day. You need to understand that that regular day can change from 3 p.m. to 7 p.m. to 11 p.m. because people are humans and things happen. And so just because you started the day out wonderfully doesn't mean that the day will end up like that. So you're constantly observing. And then you report to your nursing leadership, whoever your supervising nurse is. If you have a concern, you not only say, hey, Nancy, I think Mrs. Tic Tac she don't seem right. That's not a report. A report is, I'd like to speak with you. Here are my notes. Here are her vital signs. I think that something's going on with her. She didn't sleep last night. She slept all day today. She did not go to the activities. She refused her dinner, and her last bowel movement was 3 days ago. Now that is something that Nancy, the nurse, can say, oh, okay, Celeste, let's talk about that, or let me go back and look at her. But if you just kind of just say, hey, I told Nancy 4 times something's wrong with Mrs. Tic Tac, that probably won't get you the satisfaction. It won't get the patient the care that they need, because your intuitive sense, your message, what you're seeing isn't being related in a usable way to somebody else. So take a little bit of time, organize your thoughts, and then go tell your story. Now, in addition to that, what isn't written isn't done. That's an old nursing adage. Like if it's not written down, it's not done. I don't want to hear about it. Like they always tell you to write your notes like you are having to read them in a court trial 10 years from now, because we're not going to remember. So we have to remember completely based on what we listened to. I mean, what we wrote down. So some of my notes back, you know, when you heard patient stable, no voice, physical, what does that mean? Nothing. So if something happened and I ever had to go to trial and I had written that lame note, I'd be in a little bit of a fix. So write who, what, where, when, how, and why, write specifics. And then if you do have an impression, you could write that, but you clearly identify that as, I reported to Nancy Jones, RN, that patient's vital signs were blood pressure was lower, patient did not sleep last night, and refused dinner. And then not only, so, I mean, your job isn't done. So, because we'll go over the physical and non-physical changes, and then we'll kind of wrap it up. So what you're looking for are physical changes. These are the big ones, and everybody is unique, so everyone will have different challenges. Walking, bowel and bladder, skin, level of weakness, falls, vital signs, and then any, of course, like frank stuff like they cut themselves shaving, they start to hemorrhage, they're coughing up blood, you know, anything like that. Those are your physical changes. And non-physical changes are more nuanced: demeanor, appetite, sleeping, speech. Confusion or agitation is a big one. Residents' complaints of pain. Of course, you wouldn't know somebody's demeanor unless you knew them, really. Confusion or agitation in somebody who is normally not confused or agitated is usually a medical emergency. It's usually delirium. Delirium is usually caused by a medication side effect or an infection or maybe even a stroke. So that acute confusion or agitation is a medical emergency. Lots of times your patients are sometimes confused or agitated, but an increase in that also needs reported. Okay, so monitoring for change. I think that we went over this pretty thoroughly. Always be monitoring. It can change from 3 o'clock to 4:30. You can come back from dinner, your lunch break, and all bets are off. You could have a total different situation. So you check in, you know what you're going into, you get your shift to shift report, you check and see when their last bowel movement was, what happened for them. I mean, you don't have to read. It's not like reading Tolstoy. It's you just get the who, what, where, when, how, and why. She had a medication change today. She went for a scope earlier in the day. You kind of figure out, get a beat on, hey, I can't look at everything, but this is what I think I'm going to do. You have 10 patients, but you know one had a minor procedure earlier today and had anesthesia. This is a person you're going to put on your list and say, hey, I'm going to check on this person 6 times instead of my normally 4, whatever. So you organize your day accordingly, but you never shortchange anyone. You may upgrade someone, but you don't shortchange anybody. So residents, if changes are being suspected, this, you always see somebody, I don't know, being pulled out and by the nurses station. And back in the day, we used to always like just put them there for a while because we're like watching them. But there's some validity in that. Like if somebody you're not really sure or they seem to be not right, and you don't have the staff, you need all eyes on somebody. You don't want them alone in their room when something could happen. Who is responsible for observing and reporting? Of course, we already said everyone on the team. The team is the dietary, the janitor, the speech, occupational therapy, the nurse, of course, any direct care provider, visitors. But if you're the person in the room, everyone is responsible. But really, the direct service provider is the eyes and ears of the team. They're the ones that know. I've given the example before about the nurse's aide. We had that really confusing patient that kept falling and got very acutely confused. He was not a diabetic. And she says, I don't know what's going on with Danny, but when I lean over, his breath smells like my grandmother who had the sugar. And I was like, why would he have like diabetic breath? Like, what is happening? And so we did some evaluation. They had put him on a new medication, which was seemingly benign, but caused some alkalosis, which actually put him into kind of like metabolic alkalosis. They fixed it up and he was fine. And he had been to multiple providers trying to figure out what was wrong with him. And it was just her observation that his breath smelled like the sugar. And she just made this comment. And it basically saved his placement there and maybe possibly even his life. So I told you about there's a general rule of thumb that it takes about 3 to 5 reports. The better the report, the better the response in everything, really. So your job is not over when you tell them once. You don't some people, not any of us, but some people say, I told her. They'll spend more time complaining that Nancy didn't respond than actually going back, reassembling their thoughts and saying, hey, Nancy, we talked about that. You always have to keep your eye on the prize. My job is to advocate for this patient and it's not my ego that Nancy didn't listen to me. Okay, she didn't hear me the first time. I need to make sure, like, how can I get this message across? So that's your job, is to do it in a professional, organized way that produces results. And you can do that by the verbal report, but you also do that with the documentation, who, what, where, when, and why. I say how too, but it's just really who, what, where, when, and why. Who, of course, you're reporting it about, what is happening, where did it happen, if it did. She seems to stumble when she is getting up off the toilet, when you only see her confused or faint and dizzy when she's getting up off the toilet, and why you're thinking that maybe she's having some blood pressure changes. It's okay to have an opinion. It doesn't mean that you're diagnosing. It's okay. You know them. You can tell them that. You'll just say, I asked I took the vital signs. Why would be, I took her vital signs and her blood pressure was lower at that time. You're not saying, I said she's having low blood pressure, but you might support it with a possible rationale for why she's getting dizzy, getting up off the toilet. So the documentation is key, because remember, you might go away for 2 days and somebody that you're used to know, you tell your team member, Eliza, and Eliza's like, I got you covered. I'm working 12 hours tomorrow. We're on it. But then Eliza wins the lottery, and Eliza's a no-show, and there's some woman pulled from 3C that doesn't know the patient. So you can't rely on a verbal. The verbals are great. They're the color commentator, but you need the play-by-play documented in the medical record or however you document it. You write down your vitals. You write down if you reported any concerns. You write whether they slept, doing your flow sheets. However, that documentation must be done accurately, on time, legibly, and in a way that other people can pull that information and build a way to provide optimal care on their shift. So just in summary, recognizing changes, you want to know the baseline on all your patients. No excuse that you never worked with them before. You can go in and see, okay, and after you work for a while, you know, somebody that gains 2 or 3 pounds and has a history of congestive heart failure probably is filling up with water. You understand the signs and symptoms of low blood sugar, weakness. You know that most people need their pain meds before they go to physical therapy, or they don't do such a hot job. So you kind of get a feeling for the groove of the day. You can be very efficient in knowing what you need to pull out for each patient. Any new procedures that day, new diagnoses or whatever, that's your job to know going into the shift. Your job is to triage which people may need you more without shortchanging the rest, and actually using those physical and non-physical categories that we outlined to look and say, do I see a change? And reporting and recording it accurately. And that's all I have. I think we made it to 30 minutes, so we're good. And thank you for hanging out with me. And hopefully this was helpful. So we'll start this. And